health services. And turning to Wisconsin again, in 2011, the market value of property fell by 1.8%. And Wisconsin had much lower housing price declines than many other states, but still a decline. Largest drop was 6.4%. And one thing to emphasize is that there's a lot of variation within states. So in 16 of the 72 counties in Wisconsin, there were actually property values actually increased, but most of them saw property tax declines. Turning to federal government finance, everybody is aware, I'm sure, that federal fiscal and political policy is being driven by the need to reduce the size of the nation's debt. The problem, despite what one sometimes reads, is not a problem of the next few years. The deficits are going to decline, but a problem that's really going to face this country post-2020, when a large and increasing share of the baby boom generation are retired. Entitlement costs, particularly for Medicare, will rise to unsustainable debt levels. And that's obviously influencing everything that's happening in Washington. And it also means that whatever happens in November, whichever party comes out ahead, there will be reductions in federal funds coming to states to support local public health. The Budget Control Act of 2011, which was passed as a result to solve, so-called solve the debt ceiling crisis, mandated cuts in spending over the next 10 years of about $1 trillion. Those are in everybody's projections and supported by both parties. Additional cuts were required if the super committee couldn't come up with some sort of compromise. They couldn't. There's now sequestration, which calls for additional cuts of 7–8%. Congress may go back on sequestration. Whether that leads to smaller or larger cuts for social programs like public health is an open question. The House budget, the so-called Ryan budget, calls for very large additional cuts in non-defense discretionary spending. And the important thing to remember is that big category of spending, which covers a wide array of federal government programs, about a third of that is in the form of grants from the federal government to states and local governments. And that includes, obviously, almost all of public health spending. And estimates suggest that it's hard to predict exactly what's going to happen. The laws haven't been written yet. But best estimates to date suggest that under the House budget, grants to states would decline by about 25% in fiscal 14. And one more word about the House budget. It calls for the conversion of Medicaid to a block grant. That would be particularly significant for states, and certainly during periods of recession, when eligibility for Medicaid would go up and the ability of states to provide extra funds would be very limited. We're going to turn now to Wisconsin, and Susan's going to say a little bit about how public health delivery is structured here.
Okay, so many of you know Wisconsin is one of the states in the nation that has a strong local system. So in Wisconsin, we have independent local health departments and a state health department that's a division of a health and human service agency. Overall, we have 92 local health departments and 11 tribal health departments. Our study used data only for those official county or local health departments, the 92. Of these 92 health departments, 68 are county health departments, 22 are municipal health departments, and that might include village, town, and city. Those 22 municipal health departments actually serve 42 separate municipalities. And we have 2 city-county models health departments in the state. Most of our health departments are independent health departments, independent agencies within that governmental structure, while 24 are actually a division within a combined county human services organization. So that's a variable that we did try to look at specifically. Our health departments are quite variable as they are across the country. They serve jurisdictions from about 5,000 to over 600,000 people. About half of our health departments serve between 25 and 100,000 people. On average, about half of the revenues to local health departments in Wisconsin come from the local parent jurisdiction. We also have a certification system in Wisconsin that's sort of a precursor to accreditation, which health departments are in the process of doing now. But we looked at 3 levels of health department. There's a base that's defined in statute for level 1 or for all health departments, and then in addition to that, they can do additional services, which would allow them to be certified at level 2 and 3. So that just gives you a quick picture of our structure.
Another aspect of Wisconsin health departments are obviously where their revenue comes from. And the table before you shows that about half of the revenue in 2009, which is the latest data we have, come from parent jurisdictions. So as Susan described, those are either municipal governments or in most cases county governments. But the next most important source are federal grants for about 1/4 of total revenue. The third most important are fees and charges for services, and there are a few other less important sources of revenue. Our approach is to try to model each of the major sources of revenue separately, and we're going to start with the revenue from parent governments. We rely on data from surveys of local public health departments that give us, for each separate health department, detailed information about their revenues. We use some statistical or econometric techniques to forecast revenue where that was possible. In some cases that's not possible, and we use much more ad hoc approaches. And finally, because there's an immense amount of uncertainty. We don't know who's going to win the election, both for Congress and the presidential election in November, for example, and that's going to influence how much federal aid there will be in future years. So in order to deal with that, we've developed a pessimistic and an optimistic set of assumptions. To start with revenue from parent government, most of the revenue public health services comes from general fund revenue. There are in Wisconsin 3 main sources of general fund revenues: property tax, sales tax, which most counties have, and shared revenue grants, which are general purpose grants from the states to both county and municipal governments. And then we forecast, so that gives us a forecast of the size of the pie, and then we forecast the share of parental government general fund revenues that are allocated to local public health services. Here's an overall picture. I'm going to talk about some of the details, so I'll skip by that. Start with forecasting property tax revenue. It accounts for about 3/4 of all general fund revenue. In Wisconsin, as in some other states, state legislature has taken upon itself to restrict the behavior and the fiscal freedom of local governments by limiting the growth in what are called levies or tax collection, property tax collections. And the basic law now says over the next 2 years that levies can not increase at all except for net new construction as a percent of last year's property values. And this means that forecasting levies, property tax levies that will be available to parent governments, is really a question of forecasting the rate of net new construction. And we have data on net new construction going back a number of years. We estimated in econometrics a statistical equation of new construction as a function of the percentage change in EQV, meaning property tax base, and as a function of the growth of population and county fixed effects, which are effectively controlling for differences across counties. The equation is up there. to forecast, we estimated this equation, estimated values of alpha and beta and gamma. You can find those actually in our report. To forecast net new construction through 2014, we need population and EQV forecast for 2013. The slide describes where we get the data from to do that. Turn to next step is sales tax revenue. We forecast that, again, a regression equation, county fixed effects, and obviously that reflects the fact that some counties have almost no retail sales, some have big shopping centers, and so forth, and link it also to state level per capita sales tax revenue estimates, which are available from the state through 2014. Again, you can see the equation. Third source of revenue are shared revenue. Those are allocated by a formula in the 2011-13 biennial budget. The state cut shared revenue on average by about 10%. The allocations that went to county governments were reduced in some cases by up to 25%, on the average county by 24%, so big aid reductions. And so in the budget, 2012 and 2013 are specified, and the current budget says that those amounts going to each county and municipal government don't change in subsequent years. Now, future legislators could change that, but our base case estimate assumes those numbers. So those are really not forecast, but specified in statute. Next step is to forecast how much of general fund revenue, this fiscal pie, goes to local health departments. And our priors were that, well, maybe when the economy goes down, local governments will try to protect local health departments, and so we should find the share of the pie going up. In fact, we didn't find that. There's very little variation over time in those shares going to the local health departments, and we attempted statistically to explain variations in existing shares and were unsuccessful. So in the end, what we do is we take the data from 2002 to 2009 on the shares, do an average, and assume that that average holds for 2012 through 2014. Let's turn to federal revenue. The largest revenue, as you know, comes from WIC, maternal and child health care, immunization grants. We didn't have the data to allow us to forecast revenue from those specific grant programs. And grant amounts vary by local health department. So our base case assumption is that federal revenue will equal a weighted average of federal grants between 2002 and 2009, weighted average in each individual local health department, increased by the rate of inflation to 2011, and the changes in federal grants from 2012 to 2014 obviously depend upon what Congress is going to do, but we started with current law, and again, we don't know for individual grant programs what's going to happen. Congress hasn't determined that, but we took estimates of current law from the Congressional Budget Office and for other nonpartisan organizations. So you can see a 4% decline in 2012 was assumed, close to 9% in 2013, and about 8% in 2014. For the other sources, which vary a great deal, we used weighted averages of the revenue from each of those sources and continued them in real inflation-adjusted terms for current years. We put all those together to get our base case assumptions. As I mentioned before, we make pessimistic and optimistic cases. In general, as you can see, for instance, for sales tax or shared revenue, the pessimistic case is lower, the optimistic case is obviously higher, and optimistic and pessimistic are from the perspective of local health departments. So optimistic means more revenue, smaller cuts, and you see that in federal grants. Federal grants, again, we used the Ryan budget or some, assuming a little less smaller cuts than in the Ryan budget for a 20% cut, and smaller cuts under the optimistic case. Quickly talk about our results. These are nominal results, both in nominal dollars and per capita terms. As population rises, the growth in 2013 is actually a decline in revenue and a small growth in 2014. These are nominal dollars, so they don't take any account of rising costs. So in the next slide, we adjust for CPI, and you see declines in revenue. This is for aggregate across all local health departments, both in real and percentage terms for each of the years 2013 and 2014. We then looked at the results categorized in by local health departments in different ways, the size of population. I won't spend any time for these tables come from our report, by the certification levels that Susan mentioned, and by whether a local health department was part of a human services department or an independent department. Here we can see that if you're, there are bigger cuts if you're independent as opposed to dependent. Here's the summary of the results for comparing the base case to the pessimistic and optimistic cases. So all revenue together in 2014, the pessimistic case predicts 11% less revenue, the optimistic case 13% more revenue. The biggest variation are from sources that are pretty small and less important, like donations and private grants. The final table just shows that even though we predict declines in revenue, on average, there is a variation across local health departments. So in the base case, there's some local health departments that will have increases, although the majority have decreases. Obviously, in the pessimistic case, the proportion that have decreases and large decreases rises, and it declines in the optimistic case. Let me spend the last few minutes drawing a few conclusions. One, and this will come as no surprise to anyone, we're entering a period of extraordinary fiscal uncertainty. And I've been following state and local public finance over the course of my career, and I don't think I can imagine any period when there's been so much uncertainty about what the future is going to bring. One dimension of that is how the Affordable Care Act will be implemented, even if the Republicans and Governor Romney are elected, and who declares he's going to get rid of the Affordable Care Act. That doesn't mean all provisions will be repealed. So a great deal of uncertainty there will have an impact on local public health departments. The focus of our research has really been on the impact of the Great Recession and housing crisis on local health departments. At the federal level, we know there are long-run structural problems which are going to go well beyond the current fiscal problems and the current economic problems. The case I want to make is that at the state level and local levels, there are also important structural issues. That's the topic of another research or another presentation. But I think all their long-run problems, it's not just the problem of the current recession. Revenue forecasting is never going to be perfectly accurate. Economists don't have crystal balls any more than anyone else. But we believe, Susan and I believe, that it can reduce the uncertainty in what the future is going to bring. It's going to provide the management of local health departments with important information for budgetary planning, and particularly for planning for more than just the next year, which is particularly important in an environment of declining revenues. And by their very nature, revenue forecasting models must be state-specific. As you saw in the Wisconsin case, it depended a lot on the sources of revenue for local public health departments and on things like grant systems like shared revenue, levy limits, and so forth. But we are hopeful that the Wisconsin model can provide a sort of roadmap for design of local health department revenue forecasting models in other states. And thank you for your attention, and Susan and I are glad to try to answer your questions.
Fantastic. Thank you so much, Andy and Susan. This is I think, obviously some groundbreaking work. I've never seen work like this done in the field of local public health finance before. Obviously, these kind of financing models exist in other service domains, but I think the fact that you've done it at a local level, done it in the public health domain, makes it, I think, pretty groundbreaking work. So, are there some questions from folks on the line? You can feel free to, if you'd like to, post your question in the chat box. We can call on you and manage questions that way. Or if you're just on the phone line, just unmute yourself and speak right up. I might kick us off just by asking a question about, this is a more technical question, but did you do any work, and I've seen your paper, I just can't recall, work to look at the kind of the forecasting accuracy of your models, and whether there are certain types of jurisdictions might have larger confidence intervals or more uncertainty in their predicted revenue? I'm thinking specifically about small jurisdictions, perhaps, that might have greater instability or just less precision in their forecasting.
That's a very good question, but it's not an easy question to answer because our methodology is sort of a mixed method. So some of it is based on regression results, and some of it is based on ad hoc adjustments. It's not, I mean, the standard approach would be, if you were estimating just one source of revenue, you would do a standard error and calculate the standard errors and be able to tell people the accuracy of the forecasts in a range of confidence intervals. Given the complexity of the funding of local public health departments, it really isn't possible. And we thought quite a bit about, could we say something about the accuracy? And I'm not sure we're in a position to give you confidence intervals.
But that makes sense. I certainly recognize there's the complexity of this kind of analysis. Other questions that folks have for Andy and Susan? Well, another question I'd have, or just to ask you to elaborate. I can imagine the utility and the ways in which local public health officials might use this information. Have you done any work to, at this stage, to present these results to your colleagues around the state, and do you have a sense of how they're receiving it, how they might be using this information so far? And the second part would be, do you have some plans to actually to just kind of disseminate and translate these estimates further to make them more usable for stakeholders around Wisconsin?
This is Susan. We haven't done too much yet, but we have some plans. We're going to be presenting this at a state level meeting in September. The report that Andy referred to has gone out just to our PBRN steering committee and the health departments on that steering committee. We didn't want to disseminate it more broadly until we decided, where we were going to try to actually get this published, and we didn't want to, get into the problem of something already being published. So we're still working on that. We do have the ability, and actually have done, of running these numbers for each individual local health department, and provide. Our goal was to provide them each with an Excel spreadsheet model where they could play around with it themselves and put in, different pessimistic or optimistic models, but we haven't, again, our staff for the project sort of graduated, and so we haven't gotten more staff yet. And of course, our money ran out, and so we haven't made too much progress in that just yet. But the little bit of feedback that I've gotten from the people who did get the report was it was more about, you know, on a practical day-to-day basis, the people who run health departments and who manage budgets are really focused on the current year. And they're also focused on exactly what their county or city tells them they can budget for. You know, there's not a lot of room for flexibility. And I think health departments in general haven't been used to or haven't thought about trying to forecast over more than 1 year, because it varies so much year to year. And so I'm not quite sure, to be honest, how anybody's going to use this. Sorry, Andy. But to maybe somehow encourage managers to look farther ahead might be a good thing.
Yeah, it strikes me that this information would fit very nicely into, first of all, a local health department strategic planning process. As it's going through that process, you know, every 2 or 3 years or 5 years, whatever the strategic planning cycle is, you know, this information ought to be part of what they're factoring in, and they're doing their SWOT analysis, and they're, again, looking to craft a kind of a strategic direction for the health department over the next 2, 3, 5 years. And again, now that we have voluntary accreditation in place, and one of the prerequisites of going up for accreditation is having an up-to-date agency strategic plan. We know that more health departments are looking carefully at how to execute that plan. And again, at least for the great agencies in Wisconsin, they now have this resource to factor in. And the other piece, again, where this information might be relevant to the larger community is in the potentially in the community health improvement planning process, recognizing that your health department is one of the assets you have to move forward on community health priorities and plan for implementation of activities. And again, this information could help to shape some of those plans as well.
Let me add, Glenn, following up on your comment, I think it's precisely these future planning needs where if we can move to the next step of taking our models, which are Excel-based, and turning them into a tool, a computerized or maybe web-based tool, where each individual local health department can play with the numbers. So they have the framework there, but they can change the assumptions. And they obviously have a lot of information that we as researchers don't have. They may know about plans to raise some grant money that we're not aware of, and they can then change the forecasts for each of the individual sources and see what the implications are for their revenue streams in the following year. And so we're hopeful if we can raise some money that we can take the forecasts and turn them into really a user-friendly form.
That sounds great. I know that's more than you can accomplish in a quick strike research, but that'd be a great topic for a subsequent project and a subsequent proposal, perhaps, to do that, build that kind of an interactive resource.
Hi, this is Elaine O'Keefe with the Connecticut PBRN, and I really enjoyed your presentation. I can't say that I followed all of what you were doing there, but I think that one of the comments you just made at the end about the utility of the findings and trying to generate some individual reports for local health departments really resonates. We did a study, pilot study, our PBRN, that looked at economic decline and kind of looking at the association between local economic conditions, housing, and so on, and the degree of service provided by local health agencies. And we ultimately wrote, prepared with student help, some individualized reports that you know, may always have more power. I mean, if you look at, you can talk about forecasting, but it's the local forecast that will give you more leverage, as everybody knows, if you want to try to influence the local budgets. And so, and I really agreed with your point, Glenn, about I think there's certainly utility in this data too for strategic planning, to the extent that, I mean, we should be forecasting out or projecting out, but then you have to deal with the reality of what's available. So it's always dicey.
Thank you, Elaine, for those comments.
I don't really have a question, but I do think that if the local data could be provided, that would be tremendously useful.
Hey, Glenn, this is Anthony Chen.
Hi, Anthony. Please go ahead.
I think this is really interesting. I think it's always a challenge to localize this. But a couple of comments I have. I think that, you know, the different pots of money, which will vary from state to state and local jurisdiction to local jurisdiction, but obviously there's some, it might be helpful for people as they look at this to think about, you know, you have some categorical funding, right, which might be, you know, state funding, county funding, or whatever, which is on some kind of formula. But typically those might be on, you know, for particular programs, and that will vary also based on what the feds are funding and so on. There may be some flexible funding, which may be just more, you know, like an assessment for public health. And then I think there's this box of what grants are. And so some of this you could look at from a historical basis. So for example, with grants, if you know that year over year, typically, you know, your programs are generating a certain amount of revenue from grants, then you can try and project what that is in the future. But, you know, as you look, when you break it down to these different categories, I think it allows you to analyze them differently. One of the other things I want to comment on is that we have found that in our permitting department, we actually have a leading economic indicator, which is the number of permits we get for, you know, since we permit septics and, you know, so whenever someone's building a new house, they're going to permit a septic, and then if they're selling a house or doing a significant remodel, they have to come in and do some kind of permitting or review of that. And we were able to spot the recession about 2 years before it occurred. So these are things which, you know, the local health departments may want to look at. You know, I don't know what the structure is in Wisconsin or other states, but if they have a similar function as we do in terms of permitting septics, which is, you know, that obviously the builders were starting to see this drop in demand even before anyone else could see the changes. You know, you may be able to go back on your data and do year-over-year data and see what, you know, are predictors of these. And obviously there's some seasonal fluctuation in this, but we could see very dramatic changes over the past few years, you know, year-over-year, how this line was just dropping. And then we're actually starting to see a recovery on that. So obviously that was because the people in our environmental health division were very compulsive about trying to anticipate their fee-based revenues, and they track this every year to see if they're on target. But, you know, obviously if people are doing that within their departments, they can look and see if they're predictors, equivalent predictors for their health department.
Anthony, this is
Go ahead, Andy.
Just two quick comments. This morning on NPR, there was a story using national housing permit data that suggested that the last month the housing permits are down, but the future applications for permits, and these are national numbers, are actually up, and pointing out that that's a good sign because that is a well-recognized leading indicator. And so I endorse completely that as a good technique. On the first comment about projecting, looking at the pattern of individual federal grants, I think that's a very good thing to do, but one warning sign, I think, is that the patterns that have existed over the past decade or two are not likely to be good predictors of what we're going to see in terms of federal grants over the rest of this decade. Regardless of what happens politically, I think it's hard to see how there aren't going to be substantial reductions in discretionary federal funding, and even the most, if I can use the word, liberal projections suggest decline. So that we're at a turning point, and so that makes it particularly hard to base forecasts on past trends, particularly for individual grants.
Yeah, I think that's a great point, and I think certainly also depending if you have academic health departments, I think there's certainly been a big cut in the research grant side, right? So although assuming that the prevention public health fund doesn't get totally killed, there's also promise for additional funding on the public health service side.
Anthony,
very good point.
Sorry.
Yeah, go right ahead, Matt. I'm sorry.
Thanks, Glenn. I just wanted to echo agreement with what Anthony said about building-related permits being a harbinger or leading indicator of economic decline. We had the same experience in my health department starting in 2006 in declining well and septic permits. And interesting to note the financial performance or ratio indicators that we've been working on through NACCHO through the FUDS project do include tracking the number of building permits issued each year as part of that set of financial ratios.
Very good points, Matt. Thank you. Thank you for that. Any other last-minute comments before we close our research in progress session out and move on?
Glenn, this is Sarah from Colorado, and I have a real quick question for Susan and is it Andrew?
Great.
And Susan, I know you know this is an area of interest for us in Colorado. We have a similar phenomena of health and human service, or human services and health, public health kind of merging at our local level here. And you had said in the presentation and brushed over it, and I joined a little late, so I'm not sure if you had mentioned it before, but that health departments are actually forecasted to lose more funding than those combined with human services. Do you have any understanding of why that, or what indicates that that would be happening, or is there different revenue sources, or where did that come out, or do you have any idea of why?
Maybe we could go back to that slide. We've lost control over the slides. I think, Glenn,
yeah, let's see if I can go back for you.
There's a slide that talks about independent and human service. There you go.
There we go.
So why is this, is the question. I don't know, Andy, if you have a sort of data-driven answer for it. My sort of practice-driven answer, I think, is that because the departments that are combined, they can keep things going in public health using additional sources of revenue from their social service side, perhaps. Or perhaps they choose to do things to provide a certain set of services that's consistent with that combined health and human service model that independent health departments maybe aren't doing as much of. I'm thinking of things like home care or care coordination for foster care. Some of those kinds of services might, I don't know this for a fact, but might be more likely in a combined agency. So maybe that having a bigger pot of money to be able to shift around to support declines on the public health side might explain some of that. I don't know, Andy, do you have a better answer?
So one of the things, this is obviously work still in progress, but one of the things, so this is a result that is intriguing. So the first step might be to look at the revenue sources of the two types of local public health departments, see if there are differences there that we can explain, and if not, it suggests that suggestions like Susan's might help explain the differences. So there's a potential, and we have the data to answer that question, but we certainly haven't answered it so far.
Okay, thank you.
Great question, Sarah. I did note we got a question from somebody in the chat box asking if this study was going to appear in the Frontiers Journal, and I know that you guys have a draft manuscript in place and are looking at publication options. So we'll certainly keep people posted about when and how you're going to disseminate the findings more broadly to the public health community. And I know you're looking at a number of good options for that. So we're at time we probably should move on now. I want to thank our colleagues from the Wisconsin Public Health PBRN. I apologize for calling you referring to you by the other W state, the other very healthy northern tier W state. But we certainly are impressed by the great work happening in the Wisconsin Public Health PBRN, and thanks again to Andy and to Susan, who are two leaders at the University of Wisconsin and engaged in the research network up there for this great work. And so now we will transition to some of our more administrative items on the administrative portion of our agenda for today. We did want to give, since what we just heard about some great results that stemmed from a quick strike research project that was funded in the last round, we want to give folks an update on where we are with the quick strike research applications that we have received so far this cycle. We did do a batch review of applications that came in last month and are in the process of notifying folks who submitted their quick strike applications in July. We do have we did get a number of very interesting applications and have completed the review process for that. We sent back comments to a number of applicants already, and if you haven't received yours yet, you will in the next day or two. And in some cases, we're asking for more information and for you to respond to some of the comments that have come up during the review process. But those are moving ahead, and we again thank everyone who submitted quick strike research ideas as part of last month's batch review. Again, we do have at this stage we do have room for some additional quick strike applications. We are accepting additional quick strike research proposals. This is however, this is the last month that we can accept and review quick strike application proposals in our current year cycle, because of course we've got to allow time for you to actually complete the project in our current funding cycle, for these awards. So for that, to give you enough time for funded projects, we have to we've got to receive the last batch of quick strike applications this month. So if you are, and I know that we've talked to a number of networks who have some additional ideas and are working on proposals. If you have a quick strike proposal that you'd like to get in for the current funding cycle, please make sure to email that into us by the end of this month, and we'll get it into our last our August review cycle. And again, if you've got any questions about what needs to go in your proposal, let us know. Shoot us an email to the Public Health PBRN email account, and we're glad to do that. But so this August batch review will be our last review of quick strike applications for our current funding cycle. The current funding cycle for our quick strike research project again runs through the end of May 2013. So any projects that we fund in this current cycle will need to be implemented and completed by the end of May 2013. So again, that's why August is the magic month, is the last month for getting in quick strike applications in our current funding cycle. We anticipate having a subsequent cycle of quick strike applications following this current cycle. But our current cycle runs through May 2013, and if you want to get a project funded in that cycle, you got to get us your proposal. You got to get that proposal in this month. So again, feel free to let us know if you've got questions or on that, or if we can be helpful. We're glad to do that. And again, I know I've talked to at least 3 or 4 networks who've got some ideas in the hopper that they're working on for applications this month. So we're expecting at least a handful of additional applications to review this month. Speaking of funding opportunities, I wanted to spend a little bit of time giving you some quick insights that we gained from spending some time in Washington, D.C. last week. Actually, I went out for a couple different meetings last week, but one of them was with our colleagues. One of my meetings last week was with our colleagues at Academy Health, which is a organization that is really one of the driving forces behind the health services research agenda in our country, and our major professional home for health services research there in Washington. They were gracious enough to kind of help us connect up some meetings with some of the large federal funding agencies, particularly in the HSR world, to give us some opportunity to talk to those agencies about what's happening in the field of public health services and systems research, and in particular gave me a chance to talk with them about the great work that's happening within our public health PBRN program, and to dialogue with them about what some of the opportunities may be for public health PBRN to tap into some of these federal funding sources. And in particular, I had time to meet with Joe Selby, who's the head of PCORI, the Patient-Centered Outcomes Research Institute. And we've been talking about PCORI over the last year and a half or so. That's the new entity created by the Affordable Care Act that is really, the one health funding agency in Washington that is projected to grow in its funding opportunities over time. And then also I had a chance to go and meet with Carolyn Clancy at ARC and talk with her about opportunities for public health PBRNs within the ARC portfolio, which is a lot more constrained these days, obviously, given the budget situation, but still some interesting work happening. Both of those agencies are big into the field of what we're now calling comparative effectiveness research and patient-centered outcomes research, and we've talked about those opportunities again, at this forum and in some of our quarterly webinars over time. I can tell you that in spending an hour and a half with Joe Selby at PCORI and another hour with Carolyn last week, both of them definitely see that their portfolios of research, particularly in CER and PCOR, as being open to funding projects that would look at public health and prevention strategies from a comparative research framework. So not just treatment and therapeutics, but they are definitely open to funding studies looking at prevention strategies and prevention delivery systems through their respective portfolios. And that was very encouraging for me to hear from those two leaders, is that as they see their agencies and as they see what they're authorized to fund by Congress, they definitely see room for funding comparative research projects, looking at public health delivery systems, looking at the delivery of prevention strategies and programming through public health agencies and their delivery system partners. And so I wanted to share that with you. We're going to be rolling out some additional information about those meetings, about the insight from these leaders in subsequent venues. But I did want to share that with you briefly here today. So please keep an eye out for those agencies and for the funding opportunities coming out of those agencies. Again, both of those agencies are authorized to fund new research through the the Patient-Centered Outcomes Research Trust Fund that was created by the Affordable Care Act. That's the fund that's going to be growing over time, and that is, at a steady state, going to reach $500 to $600 million a year in research funding. And so that's, we think over the long run that it's going to be important for us to figure out how to position our public health PBRN research to more of our research to fit within those funding priorities. We'll make sure to continue to profile the research opportunities that come out of those agencies and others in our newsletter and on our website, so please keep an eye out for that. I also invited Joe Selby, since PCORI is the new kid on town, new kid on the block. I invited Joe, and he accepted to write an editorial for us in the new Frontiers in PHSSR journal, kind of outlining his view of what some of the public health and public health PBRN research opportunities are coming out of PCORI. So he accepted that, and so we're going to be working with him to develop that. So stay tuned. For more news from PCORI about opportunities for research. Also wanted to mention on the policy translation front, again, this is something that we're paying a lot more attention to now, and as we're a more mature program. Some of our first cohort of PBRNs are nearing their fourth birthday party, and so obviously we're getting more research findings coming out of the PBRNs. And so we're paying more attention to how we can best position those findings to be useful in the policy arena, and to translate your research findings into policy implications, into policy stakeholders. And so we wanted to remind you of that, and remind you to please let us know as you have findings and products coming out of your research, particularly findings that might have some policy salience, like the one that we just heard from Andy and Susan. Please let us know, and we can help start to think about ways of positioning your findings to policy audiences. Last week when I was in Washington, I also spent some time with folks over in the White House Office of Management and Budget, which is obviously a very important translation arm of the federal government, and in particular the folks who work on public health priorities at OMB are very interested in what you all are doing. They're very interested in the public health PBRNs, and very interested in the kind of research that you all can produce from a policy translation standpoint. So they open the door to us to and really want us to be providing them with regular feeds of findings that might be useful to, again, a federal audience, helping the feds understand what we should be investing in from a public health and prevention standpoint, helping the feds think about things like funding streams, payment policy, the kind of things that that OMB has influence over. So we've got now an open door to channel information to the stakeholders there at OMB. We want to remind you of that, and again, please let us know if you've got findings that might have some interest and utility and salience in that audience. Let us know, because we have ways of getting that over to stakeholders like our friends at OMB. Interestingly enough, one of the public health analysts at OMB in a former life worked on the ASTO public health expenditures project that was started back in the 80s through the 90s, and so he was very familiar with the kind of work the kind of data and data limitations that we're working with in the PHSSR field, and interested to hear about some of the progress that we're making in that front. So just wanted to make sure that folks know about that window that we have open for us, and please stay in touch on your findings. A third point, just to cover on dissemination, and wanted to again reiterate that we do have the new journal up and running, the open access rapid cycle journal Frontiers in PHSSR. We're working on the third issue that will be coming out later this month. We're excited to see both the volume and the quality of submissions in that journal to continue to increase as since our launch at the Keeneland Conference back in April. Again, we'd love for you all in the public health PBRNs to make use of that vehicle as a way of getting early findings out quickly, to stakeholders that can use it. Again, also a reminder that we have a very useful relationship with the American Journal of Preventive Medicine. So if you publish in Frontiers, you've got a fast-track publication opportunity for publishing your subsequent full-blown scientific article in a later version of the American Journal of Preventive Medicine. You'll see the first example of that actually in this month's issue of the American Journal of Preventive Medicine, a paper by Ross Bronson and colleagues that I've got on my desk here. They originally published a brief version of this analysis in Frontiers last month. Their study looking at evidence-based administrative practices in public health, and a review and synthesis of the evidence on evidence-based administrative practices in public health. If you saw last month's Frontiers, you saw the brief version. If you go on the online version of AJPM this month, you'll see the full-blown edition of that scientific article in AJPM. And so this is, again, we think a very nice 1-2 punch of getting early findings out through Frontiers, getting your full-blown scientific article out subsequently in AJPM, reaching larger and more diverse audiences of people who can really make use of your research. So I just wanted to make folks aware of that that vehicle, and please make use of it. Any questions on those items? I know I've gone through a couple of items pretty quickly. Let me pause and see if there are some questions or comments before I move forward with our last couple of administrative items. I can see there's a Bill Livengood gave us a question on the chat asking about a projected time frame for. Yes, thank you for the reviews from the QI issue of Frontiers. Thank you for that question, Bill. As many of you know, who were, we had about 5 networks who were funded through a special solicitation for QI and accreditation-related quick strike research projects. Those projects are all in a state of completion now, and you all are disseminating research from your projects. And we asked a number of you who would be able to submit results for a special issue of Frontiers devoted, really featuring those QI quick strike research projects. We did receive from 5 of our networks submitted Frontiers articles for that issue. Those are in review now. Bill, you ought to be getting comments back from those articles very shortly. I know that we've got a 10-week cycle time that we use from submission through review and publication decision, and so those have been in review for a couple of weeks now. So you should be receiving reviews from your submissions very shortly, comments from the peer review process. It'll be a fairly rapid turnaround time to respond to those comments. Typically, we ask for responses within a week or 10 days after receiving those comments. And then those can go into publication. Right now, we're slating that special issue of Frontiers that will feature these QI projects for the September issue of Frontiers in PHSSR. So the August issue will be out shortly this month, and these barring any unforeseen snags in our publication process, we should be able to have the special issue of Frontiers on QI quick strike research from the PBRNs out next month as the September issue of Frontiers. Thanks for that question, Bill. So not hearing other questions or comments. Let me move ahead. We did want to reiterate some of our other dissemination channels. Recently, our staff has teed up a LinkedIn group for our colleagues in the public health PBRNs who are users of LinkedIn, which is the social media site for professional interaction and contacts. And so, those of you who are LinkedIn users who are willing to enter the foray of LinkedIn social media, we invite you to join our public health PBRN group on LinkedIn you can see the website here. Clicking on that URL will allow you to join your our LinkedIn group. I think you've got to have a LinkedIn account set up for yourself before you can do that. My staff will correct, my more social media knowledgeable staff will correct me if I'm wrong on that. But I think you need to set up your your personal LinkedIn account first, which is really easy to do, and then you can join the Public Health PBRN LinkedIn group. We encourage you to do that. We're exploring some new ways of kind of supporting peer-to-peer interaction through the PBRN program this year, and this is another way that we're testing out doing that. So we encourage you to get on LinkedIn and use that as you if that's something that will fit within your agenda. And we'll be sponsoring some conversations and interactions through that LinkedIn network as we go forward. I'll also mention, as part of those of you who are part of our Improve study, the networks that are part of our multi-network Improve study, we're also testing out we set up a Google Groups platform for doing asynchronous conversation and discussion on some of our measures to be used for the Improve study. So we'll share with the larger PBRN group our findings about how the Google Groups platform works as another platform for asynchronous communication and interaction as we move forward. Other meeting agenda items here, you see here on this slide, these are some of the other upcoming meetings. We've got APHA that's coming up at the end of October. We know a number of you will be presenting PBRN research findings there at the meeting. If you haven't already, if you've had an abstract or a session accepted that includes some of your PBRN work, please let us know. Send us your abstract to the PBRN account. Send us your presentation once you have that ready. We again really need to get your products as you're producing them to us, so we can help you with dissemination and getting the word out. And we like to hear ahead of time when you've got presentations at meeting schedules again, so we can add that to our communications work. So let us know on that. I'll also, although it's not mentioned here, again, those of you who are part of our Improve study know that we are going to be convening for a day-and-a-half meeting as part of the Improve study at the beginning of October in Colorado, October 1st and 2nd, Monday and Tuesday. We'll be having representatives from our our participating Improve networks convene in Colorado to help us make the kind of final selection of core measures to be included in the Improve study. Our staff will be sending out more information to our Improve networks about how to get your travel arrangements set up. We'll be doing that centrally, setting up your travel and hotel, etc., through our staff here at the PBRN Coordinating Center. So look for more information from us in an email about how to arrange your travel for the Improve meeting that will happen on October 1 and 2. Next month, our next monthly virtual meeting will occur on September 20th. Our Research in Progress section will feature our New York Public Health PBRN and some very interesting work underway there. So you won't want to miss that. Make sure that's on your calendar for September 20th. And then finally, we've just got some other updates about our PBRN program to give you. We do have, as part of our PBRN team, we do have a new student who'll be rotating on to work with us, a new incoming doctoral student here at the University of Kentucky, Mary Lou Wallace, who will be joining us and doing some work with us. She's just arrived in Lexington this week, so you may see a new name pop up in our work this semester, and that's Mary Lou Wallace. I'm not sure if she's on the call today with us or not. She may be in orientation today, but she'll be helping out and joining our team to help with our work of the public health PBRNs. She's a great asset. She is here. All right. Hi, Mary. You want to say a quick hello?
Oh. Hello, everyone.
So that's Mary Lou's voice, and she comes to us actually from the University of Arkansas, where I was previously. She got her MPH there from Arkansas and has moved in to get her doctorate with us at the University of Kentucky. So we're glad to have her. Has done work in obesity prevention policy and has a real interest in community-based public health. So we're great to have her with us. Another quick update, as we've mentioned previously, we're reinstituting our quarterly telephone calls with our networks, putting back online a quarterly telephone interview schedule with all of our networks. This is what we use to kind of get an update on the status of your research projects, the status of your networks. If anything has changed in terms of membership, anything that organizations that are part of your network. Anything that has changed in terms of your core staff or leadership. This gives us a chance to get updated on that, to make sure that we're up to date on the status of all of your research projects that are ongoing through your network. Any products that you've produced, to make sure that we're up to date on those, or new products that you've got on deck that we can be anticipating. Those kinds of things. We kind of had suspended that a little bit during the transition, but we want to start that up again. We found it very useful. It also gives you a chance to tell us, in real time, give us your insight about things that are working or not working with our operations at the coordinating center, and ways that we can be more effective in helping you do the great work that's happening in the public health PBRN. So our staff will be in touch about setting those up, getting we typically do that with a key contact. One of your key leaders in your network, do that call on a quarterly basis, the check-in call to get us caught up and up to speed with everything that's happening within your network. So look for updates and scheduling on that. Our last item here, just on technical and administrative assistance from the coordinating center. Just a reminder that we are here to help you provide assistance with any of the technical aspects of getting your research done. As you have projects underway, if there are areas of uncertainty where you need assistance, whether that's with research design, analysis, or communication, dissemination activities, we can help with that. We can provide that directly with our internal staff. If we don't have the expertise, we can connect you to colleagues that we have around the country that can provide that expertise. So let us know as you have those TA needs. Also on the administrative side, we want to be your first point of contact if you need help or you need clarification on what needs to go in your annual narrative reports, how you can request a budget modification, how you can request an extension if you need an extension of your timeline to get projects done, what you need to do to notify the foundation of any changes in your proposed scope of work or any changes in your key staff of your funded projects. We can help you with that, all of your reporting requirements. So please let us know. And again, as the National Coordinating Center for the PBRN program, the foundation wants you to come to us first. We're supposed to also be kind of offloading that work and reducing administrative burden that comes directly to the foundation. So please, as you've got questions about reports, budget mods, extensions, any of those things, please send those to us first. If you need a proposed modification approved, those have got to come to us first. We've got to approve them and send them on to the foundation before the foundation can process them. So just a reminder that to please come through us as you've got those kind of administrative needs that come up related to your RWJF funded public health PBRN research. Any questions or comments on those items? This slide just gives you a reminder of where some of those guidelines are for reporting and administrative functions. They're here. They're also always on the monthly newsletter, the email newsletter that we send out, and these links are also on our website. So they're good to keep in mind as you've got reports coming up, annual reports, final reports, bibliographies, etc. And that does remind me. We mentioned last month that the foundation has commissioned an evaluation of their PHSSR portfolio of activities, and that the Urban Institute, some strong colleagues from the Urban Institute, Candy Hatchery and Randy Boberg, are leading up that effort for the foundation. Included in that evaluation, they'll be taking a look at the Public Health PBRN program and looking at the great work that you all are doing and wanting to interview and actually perhaps do some site visits with selected PBRNs. So many of you may be hearing from Randy and Harry very shortly about their evaluation work. In preparing for that, they're obviously going to want to get a handle of the great work that's happening there, happening in your PBRN. So it's a good idea, it's a good idea in general, but especially as we know, evaluative work is in the pipeline. It's a good idea now to make sure that you've got an updated bibliography of the research products that have been produced through your PBRNs. Make sure you've got a catalog of your publications and presentations and any research briefs, policy briefs. That's a good thing to have updated anyway for your PBRN to disseminate to the variety of stakeholders that are interested. But that's something that obviously would be real handy to be able to provide to Randy and Harry as part of their work. Similarly, keeping an update of your the registry of your PBRN participants. Which organizations are active participants in your network? Who's serving on your steering committee or governing body or leadership team? The kind of making sure that you've got some updated documentation about your membership and composition and leadership would be a good thing. A good thing to do as well, because that's always good to keep that stuff up to date. But likely that's information that will be useful to Randy and Harry and the evaluation team that they have. Any questions on that? We got just a few more minutes left, and so any questions on that or other items to consider for the good of the order before we sign off today? Lizette or Anna or Mary Lou, any other comments from our PBRN staff before we sign off?
I think we're all set. Thank you.
Fantastic. Well, again, remember we did archive today's session, record it. So if you've got colleagues who want to hear more about the great work about Wisconsin's financing forecasting model, that'll be archived on our website. Again, don't hesitate to contact us as you have questions or needs or ideas about the Public Health PBRN program. Keep your cards and letters coming, and we'll stay in touch as well. Thanks so much, everybody.
Excellent.